Hello, everybody. This is Dr. Gonzalez. I have put together this lecture for all nurse practitioner students, specialties who are in Texas to help you understand what the laws are in Texas and how they shape your scope of practice. It is so very important that you know the various laws and what they say because you are obligated to follow all state, federal, and local laws as they relate to what you can and cannot do as a nurse practitioner. That is clearly stated in the Board of Nursing Regulations. And what I really want to impress upon everybody is that it's not just the Board of Nursing rules and regulations of the Nurse Practice Act that shape our scope of practice. There are many things outside of that that regulate what we can and cannot do, which is why I say it's so very important for you to have a working knowledge of this, particularly when you graduate, because when you get out into the real world, you will be asked and put in different situations that will call for you to be your own advocate and your own patient advocate, and your patient advocate as well, so that you don't do something you're not supposed to, which is illegal. In other words, not permitted by the law. So anyway, you're not going to remember everything in this lecture, but hopefully you will know that, oh, wait a minute, didn't Dr. Gonzalez say something about that lecture whenever it was you listened to it? So that's the purpose of this, to introduce these concepts to you so that if you are ever in a situation where you think you should not be doing something, then you might remember or recall from the lecture that, oh, he said something about this, and it will help you in that instance. So this lecture focuses the examples that I have in this lecture tend to be more adult, but remember that these scenarios could very easily be a neonate, could be a psychiatric person, could apply to the gerontology population or the pediatric population. So the laws do not differentiate necessarily between pediatrics, neonatal, adult, geri, or family. They are what they are, and so the situations I have may have an adult scenario in it, but that doesn't mean it doesn't apply to the neonate or it doesn't apply to the pediatric population. So be aware of that. With that, we'll go ahead and get started. So this is kind of what I feel about the scope of practice. And if you've heard me talk about scope of practice previously, um, you'll know that I think that scope of practice has a lot of blurry lines, and it's really hard and difficult at times to understand what we can and cannot do, which is another purpose for this lecture for our Texas graduates, because there's a lot that affects what we can and cannot do, and I want everybody to be prepared when they come out. So why is scope of practice important? Well, it's important for two main reasons. Think about these two main reasons. One, practicing within your scope keeps the patient safe and ultimately decreases your liability. The Texas Board of Nursing says and requires us all to practice within our scope of practice, and ultimately doing so leads to better patient outcomes and patient safety. The point of us working within our scope of practice is that we are all trained in certain populations, and we have our specialty, and one specialty is not necessarily better than the other, but they are very different. And so unless you have the formal training to work within a particular specialization or population, you are not trained to take care of them. So how can you safely take care of a patient without causing them harm? And so that's why scope of practice is important, because it keeps our patients safe and it decreases our liability. So some scope of practice general considerations. So let's look at some definitions. Scope of practice are those activities that we do on a daily basis when providing care for our patients. The pillars of scope of practice are our education, our licensure, and certification. So the education is what population were we educated, formally educated on in school to care for. If you're a family nurse practitioner student, your education was in family medicine across the lifespan. An adult gerontology student in acute care, their population is acutely and critically ill patients, 18 years and up. And so the education is what we were formally educated on. If you're a PNP in primary care, that's your formal education. If you're a neonatal MP student, that's your education. So we are educated in a population. We sit for national certification, which validates our education, and then we get licensed in our state. Licensure is the authority to practice in an individual state. So those are the three pillars of scope of practice that form the foundation of our scope of practice and what we can and cannot do. So let's look at this question here. Is the RN scope of practice versus the MP scope of practice different? And the question, the answer to that is, of course, it's different. It's very different between what we do as an RN and what we do as a nurse practitioner. As a RN, we do not have quite the responsibility that we do as advanced practice nurses or nurse practitioners. As a nurse practitioner, we are making medical diagnoses, we are making treatment decisions, we are prescribing and or ordering treatments, whether they're medication related or non-pharmacologic therapies. We are following that patient for improvement based on the therapies that we have ordered. And so the level of activity and the level of responsibility that we have as nurse practitioners is much greater than what we do as a registered nurse. And so as a registered nurse, we have our nursing assessments, we have our nursing diagnoses, but a lot of what we are held accountable to as nurses is following orders. And so while there is a significant amount of critical thinking that we have to do at the bedside on a daily basis as registered nurses, the scope of practice between the two roles is definitely different. There is no way I would want to do what I do as an acute care MP without having my education or my educational background or certification. Doing what I do as an MP without that education, it would not be smart at all, would not be uncomfortable. And there are days where I'm still not fully comfortable and I doubt myself. And so, and that's even with the appropriate education. So anyway, it's important that you understand that the roles are very different and what we do as MPs is much different than what we do as an RN. So let's look at our first case scenario here. An RN worked in critical care for 10 years and goes back to school to become an FNP. The RN wants to work in the ICU setting after graduation because she has 10 years of RN experience in this setting. Is this possible? How does the RN experience impact MP scope of practice? So the answer is the RN experience does not have any impact on your scope of practice as a nurse practitioner. And why is that? And I just talked a little bit about that already, so I won't beat it up again, but the roles are very different. So what we do as an RN does not qualify us to do advanced skills as an APRN. Certainly our RN experience helps us overall, but it does not expand our scope of practice. So as an FNP, she cannot work in the ICU setting regardless of her RN experience because that is officially out of her scope of practice. Her RN experience does not qualify her to work in the ICU setting. Expanding scope of practice has its limits without going back to school. So one cannot extend into another APRN role without having the formal education, certification, and licensure of that role. So let's say, for example, an adult geriatric acute care MP cannot start seeing pediatric patients in the acute care setting without going back to school to become an acute care pediatric MP, or an FNP or women's health nurse practitioner cannot go back to cannot start delivering babies without going back to school but to become a certified nurse midwife. And likewise, an NMP cannot see pediatric patients in the hospital settings because their scope is limited in age. So you have to have the appropriate education, certification, and licensure to expand the scope into another APRN role. So the Texas Board of Nursing gives us a definition of scope of practice. So how does the Board of Nursing define APRN scope of practice? That's what we're going to look at next. Texas Board of Nursing's scope of practice definition. They define the scope of practice as those activities and procedures that we do while delivering care on a daily basis. They recognize that the scope of practice is variable and highly dependent upon one's education and certification. In Board Rule 221.12, which is titled Scope of Practice, they say that your scope of practice is defined by those national nursing organizations that govern the respective populations. These organizations have to be recognized by the Board of Nursing, and most of those national organizations, as far as I know, are recognized by the Board of Nursing, and their definitions of scope of practice are generally accepted across the country. So the APRN scope of practice, they say, is in addition to the RN scope of practice, and they are very two distinct different roles. They identify that there is two different types of scope of practice. One is a professional scope of practice, and the other is the individual scope of practice. And so the professional scope of practice, they say, is defined by those national nursing organizations. And so, for instance, for the pediatric NPs who are particular in primary care. The Pediatrics Nursing Certification Board, PNCB, defines that scope of practice. For psychiatric nurse practitioners, the scope of practice is defined by the American Nurses and Psychiatric Care Association. That's not exactly the name, but it's APNA. And so Anyway, the individual scope of practice, they say, is formed by your education and experience. They recognize that you can evolve in your individual scope of practice, but also they say that there are finite limits to how far you can push or expand your individual scope of practice. So in other words, you can expand your scope of practice, your individual scope of practice, provided that you are working within the confines of your professional scope of practice. So the best example I can come up with is me as an acute care nurse practitioner. I work in a hospitalist service per diem. And if I wanted to transfer to a critical care and start working in critical care and then learn how to intubate individuals and drop lines, that is something I can do given that my educational background, my certification and licensure is with the acute care population, the adult population. So I am therefore able to expand my scope of practice to that. However, I cannot go and expand my scope of practice and start seeing pediatric patients, for instance. So whose responsibility is it to ensure that you practice within your scope of practice? The example that we have here is the certified nurse midwife accepts a job as a hospitalist service. Is this within their scope of practice? And so the answer to that is no. Ultimately, you as an individual are responsible for ensuring that you work within your scope of practice. You will be asked by physicians, or you will be put in positions by your employer that they will ask you to do things that are not appropriate. They're not within your scope of practice. You have to be able to say no and tell them why you cannot do that. And you have to know that you cannot do that, because you will be personally liable and accountable for practicing within your scope of practice. Just because a physician says you can do it does not mean you can do it. And I have run into many encounters where I've had to push back and say, no, I can't. So it's important that you understand what you can and cannot do based on your state laws. And we're focusing on Texas, and so of course, so we'll say Texas laws, but nothing shuts down a person quicker than you say, no, it is against the law, I cannot do that. But you have to know the law and be confident in your knowledge and point them in the right way. Employers are not going to know who what your scope of practice is. They're just going to assume that you can do anything. And if you hear a physician ever say, well, a PA can do that, well, the PA works off of the physician's license. Their license is bound by to the physician's license. Ours are not. So PAs, basically their scope of practice, and I'm not experienced at knowing what their scope of practice is, but essentially their scope of practice is what the physician says it is. That's why physicians will come to you sometimes and say, just do it because I've said to do it. And that's not the case for nurse practitioners. We are still held accountable to the Nurse Practice Act, and everything that says into it, and our standards of standards of practice. And so we have to say no when it's appropriate to say no. So how do I determine if it's within my scope of practice? Well, I'm glad you asked. The Board of Nursing does give us some guidance on this, and they recommend that you answer these questions to determine if it's within your scope of practice. So the first question is it consistent with one's professional scope of practice? So is it consistent with how the National Nursing Organizations define your scope of practice based on your population: adult geri acute care, adult geri primary care, FNP, etc. Is it consistent with statutory or regulatory law? So is it allowed? Is it legal? Whether it's a state law or a federal law or a local law, is it legal for you to do this? If it is, then it's likely within your scope of practice. If it's consistent with your professional scope of practice, then it's likely within your scope of practice. Is it consistent with one's education, the role and specialty? That kind of coincides with the professional scope of practice, but the general idea is if you were educated on it, then it is likely within your scope of practice. Is it consistent with one's recognized title, or does it evolve into another advanced practice title? So the idea of this is if it evolves into another APRN title, then it's not within your scope of practice. There are some exceptions to that, but as a general broad rule, if that occurs, it's not within your scope of practice. Is it consistent with the standards of nursing practice outlined in Board Rule 217.11? If it is, then it's within your scope of practice. Is it consistent with evidence-based care? The Board of Nursing does require us to practice evidence-based care, which is why this is a question. Is it consistent with reasonable and prudent practice? And are you willing to accept accountability and liability for the activities and outcomes? So those are your guiding questions when you have a question about whether it's within your scope of practice. The Texas Board of Nursing does expect that all of us, MPs and otherwise APRNs, practice within their professional and individual scope of practice. And they also recognize that the individual scope of practice may be different from person to person. So how does national nursing policy define scope of practice? So you got to have a good sense of this because the Board of Nursing's rules require us to know that so that we are not practicing outside of our scope. So the APRN consensus model, this was published in 2008. You may or may not have heard of it, but hopefully you have. And so this was a national nursing policy from a number of national organizations that came together to help redefine the APRN populations. And the focus of this was to get consistency in licensure and education across the country, to help with portability across state lines, to help boards of nursing be able to validate an individual's education much easier, and ultimately the ultimate goal was to increase patient safety. Before this consensus model came out, we had a number of different things happening. You would see, if you looked at nurse practitioner programs prior to 2008, you would see that some people were preparing people in as an oncology nurse practitioner or an occupational health nurse practitioner or a nephrology nurse practitioner. So we have a lot of inconsistency in the education. And what was happening is when they crossed state lines, if it wasn't necessarily in Texas or the person's home state, and they were trying to go to another state, boards of nursing did not know how to validate minimum educational requirements, and so it was making licensure very difficult for NPs and or even APRNs. So, but the biggest thing that came out of this was a whole definition, a whole different concept about scope of practice. The biggest concept about this, about scope of practice that came out of APRN consensus model was that scope of practice is based on the patient's needs, not their physical location. And that's a very key concept for you to remember, regardless of whether you are a neonatal NP, a psychiatric NP, a pediatric primary or acute care NP, adult geri or family, etc. This is your guiding principle. If it for you to define your scope of practice. So if it is the patient's needs, what do they need from you as a provider that defines that scope of practice and not their physical location, which is huge, and sometimes there's a lot of gray areas, so you have to be comfortable with understanding that concept. So let's look how national organizations define the individual scope of practices of the various nurse practitioners. For the adult geri acute care NP, that scope of practice is defined by the American Association of Critical Care Nurses. They define the scope as the provision of care for those individuals who are acutely or critically ill, technologically dependent, have rapidly changing conditions, are highly vulnerable to complications, are physiologically unstable, have an acute injury, terminal illness, or those who are chronically complex ill. The age range is typically is late adolescence and up, and usually most people will define this as 18 years and up. So the adult gerontology primary care NP, there's not a one particular national organization that defines primary care role, whether it's adult geri or family or pediatrics, but the definition of primary care comes to us from the National Organization of Nurse Practitioner Faculty, which is the organization that helps to define competencies that each NP graduate should come out being able to achieve. And so anyway, so the adult geri primary care NP, the primary care is defined as those NPs who are educated to provide comprehensive, chronic, continuous care characterized by a long-term relationship between the patient and the primary care NP. The primary care NP provides care for most health needs and coordinates additional health care services which are beyond the primary care NP's area of expertise. Typically, adult gerontology primary care NPs start at age 12 or 13 and go to the end of life in the population that they are caring for. So the family nurse practitioner, the definition for primary care is the same as what I just read to you for the adult gerontology NP, so primary care NP, and I won't read that again. But what you want to see about the FNP is that their age span is across the lifespan, so they can care for individuals from the time of birth to the old age. So that's what's different with the family nurse practitioner. So we have the family psychiatric mental health nurse practitioner. Their scope of practice is defined by the American Psychiatric Nurses Association, or APNA is the acronym, and they are trained to provide continuous and comprehensive mental health care, including assessment, diagnosis, and treatment across settings, which means inpatient and outpatient practice settings. They provide care to individuals, families, groups, communities from pre-birth to end of life. So the psychiatric family health nurse practitioner, they provide psychiatric care across the continuum. So they are trained to work with patients on the inpatient setting, on the outpatient setting, and across the lifespan. So they have a very different scope of practice than most of us. So let's look at the pediatric nurse practitioner. The pediatric nurse practitioner in acute care, their scope of practice is defined by the American Association of Critical Care Nurses. So if you ever look at their definition, they in their scope of practice document, they say that their document is for all nurse practitioners who practice in the acute care setting. So it encompasses the adult geri acute care NP and the pediatric nurse practitioner in acute care. And so they are the main person who defines the scope. The Pediatric Nursing Certification Board validates the AACN's definition of the role, and so they are in agreement with the role. And again, it's the same definition um, for as the adult gerontology acute care individual, and so it's the provision of care for those individuals who are acutely or critically ill, technologically dependent, have rapidly changing conditions, are highly vulnerable to complications, physiologically unstable, acutely have an acute injury, terminal illness, or those who are chronically complex ill. For the pediatric population, or the pediatric nurse practitioner, whether it's in acute care or primary care, they both treat patients from birth to age 21. And on the primary care side, their role is defined by the Pediatric Nursing Certification Board, and they define the role of the primary care NP practitioner as one to provide care to children from birth through young adult with an in-depth knowledge and experience in pediatric primary health care, including well child care, prevention management of common pediatric acute illnesses and chronic conditions. This care is provided to support optimal health of children within the context of their family, community, and environmental setting. The primary care certified pediatric nurse practitioner role is designed to meet the specialized physiologic and psychological needs of children in the areas of health maintenance and promotion and assessment and management of disease processes. So you can see when you compare those two definitions how different those definitions are between the acute role and the primary care role. And again, they treat from birth to age 21. So the neonatal nurse practitioner, their scope is defined by the National Association of Neonatal Nurses, and they say that the neonatal nurse practitioners have specific competency standards encompassing wellness through critical care in the population of neonates, infants, and toddlers through 2 years of age. So these individuals, if you're a neonatal nurse practitioner student, you are trained across the continuum care, so inpatient and outpatient, from pre-birth actually or preemies through the age of 2. So the NMP education standards have evolved beyond acute and chronic care to include primary care across the continuum. That's enough to be said there. So the FNP scope of practice, common thoughts. I hear these often from students. I've heard this from students before. I've heard this from new graduates. I've heard this from practicing FNPs. And I've heard this from persons who decide to choose a FNP program. And so I wanted to kind of address these common thoughts here. I'm a family nurse practitioner. I have a broad education. I can do anything. I want to go to FNP school because I can do anything. Are these statements true? Well, not necessarily, which is why we want to talk about them. So the Texas Board of Nursing's response to this, to these questions can be found in a webinar where they discuss scope of practice, and they say that they actually get similar questions and they want to address it. So the Board of Nursing's position on this is that FNPs have a broad scope of practice that does not include the same depth in particular areas as those APRNs with more limited population focus areas. The APRN must have been educated not only in the provision of the service, but also in the response to and medical management of untoward events, adverse reactions, or complications experienced as a result. So what that means is that you can't just be taught how to start treatment, let's say for DKA, and then say, oh, this is within your scope of practice. There's a lot of potential complications that come with that, not just from the disease process, but also from the treatment. So if you're giving IV fluids and you're giving IV insulin to this person who has DKA, they probably have a metabolic acidosis. They probably have electrolyte imbalances. They may have an acute kidney injury. They may have a silent MI. And if you don't know how to treat all these potential complications, then it's not within your scope of practice to treat that type of patient. So they're saying that you have to be taught on a vast majority of things to consider it consider something be within your scope of practice. So Board Rule 217.11, Standards of Nursing Practice, 1B specifically says that it requires all nurses to implement measures to promote a safe environment for clients and others. So when we, whether it's an FNP or a neonatal NP or an adult geri NP, when we are working without or outside of our scope of practice, what the board will say is that we are not promoting a safe environment for clients, and they will hold the individual accountable for a violation in 1B of 217.11. Also, 1T of this same rule says that we should only accept those nursing assignments that take into consideration client safety and that are commensurate with the nurse's educational preparation, experience, knowledge, physical and emotional ability. Again, this ties us into practicing within our scope of practice, and if we choose not to practice within our scope, then we can be held in violation of this 1T section of 217.11. So it's important for me to point out that all the RN standards of practice, everything in the Nurse Practice Act and the rules and regulations apply to us as APRNs or nurse practitioners. And so just because we're a nurse practitioner doesn't mean that the RN specific rules do not apply to us. So we have to be aware of that. Board Rule 221.12, Scope of Practice. We've discussed that already, and this requires us to practice within our scope of practice, and it defines that, tells us that the national nursing organizations define our scope. FNP programs may discuss and teach about acute care diagnosis such as DKA, but the focus is on the recognition of the diagnosis and referral to the appropriate level of care, not the full treatment of the diagnosis and its complications. So that's where the education is different, and I kind of sort of already talked about that already. So, but that's what makes it different. You have to be able to recognize it, but just because an FNP is taught to recognize it doesn't mean they have been taught the full gamut of treatment for that individual. And so it's important that we know our boundaries. And so this is why those common questions about FNP or those common statements are not necessarily valid. Now, they may have been at one point prior to the APR consensus model, but they're not now. And so that model, when it was published in 2008, changed scope of practice forever for everybody. So what I want to do is take you through the various laws in Texas that impact our scope of practice. And because the Board of Nursing's rules and regulations are the biggest one, we will start with them, but then we'll take a look at a couple things in the medical board rules and regulations, the pharmacy rules and regulations, the health and safety code, transportation code, etc. Because there's many things, but the Board of Nursing rules and regulations are the biggest. So for the next number of slides, we'll be looking at some of the specific rules for the Board of Nursing, and then we will move on to the other areas. And so you'll see we'll have a slide very similar to this introducing the next major area of law that we'll discuss. So you should know that until you see the next large slide that we're still working on the Board of Nursing rules and regulations. Continuing competency. Board Rule 216.3 says that a nurse must complete 20 contact hours of continuing education in the nurse's area of practice every 2 years or obtain and maintain national nursing certification which is approved by the Board of Nursing in the nurse's area of practice. So APRNs are nationally certified by a national certifying board approved by the Board of Nursing, and therefore meets this 20 contact hours of continuing education by maintaining that national certifications. However, you want to make sure that you always maintain the specialty requirements for continuing education by the board, and those requirements are what we'll talk about next. So APRNs who have prescriptive authority are required to obtain at least 5 additional contact hours of continuing education in pharmacotherapeutics. One who prescribes controlled substances must have at least 3 or more additional continuing education hours related to prescribing controlled substances. APRNs who have entered into a prescriptive authority agreement, which allows them to prescribe opioids, are required to complete 2 hours of continuing education annually regarding the safe and effective pain management related to prescription of opioids and other controlled substances, including education regarding reasonable standards of care, the identification of drug-seeking behavior in patients, and effectively communicating with patients regarding prescription of an opioid or other controlled substance. The APRN who practice includes prescribing or dispensing opioids must attend at least 1 hour of continuing education annually covering best practices, alternative treatment options, and multimodal approaches to pain management. This applies to all license renewals that occur on or after September 1st of 2019, and this education requirement does have an expiration date. It expires August 31st in 2023. 2 hours of continuing education on approved procedures of prescribing and monitoring controlled substances is required for any APRN approved to obtain information from the prescriptive monitoring system. This is a one-time requirement, and for those who were licensed prior to September 1st, 2020, this must be completed no later than September 1st, 2021, and those who were licensed after September 1, 2020 must have this requirement completed no later than 1 year after the initial licensure date. And as an FYI, Category 1 continuing medical education contact hours can be used to meet the continuing competency requirements. So we're continuing to look at continuing competency requirements. So there's a rule for forensic evidence collection, continuing competency, and this states that an RN, including an APRN who's employed in the emergency room setting, must complete a minimum of 2 hours of continuing education in forensics evidence collection within 2 years of the initial date of the nurse's employment. This is a one-time requirement and applies to the following nurses. A nurse whose home unit is in the ED, a nurse who floats to the ED or has scheduled shifts in the ED, a contract nurse whose employment relationship includes working in the ED, and then 3 hours. These hours count toward the completion of the 20 hours of CNE required by the Board of Nursing. APRNs whose practice includes the treatment of tick-borne diseases are encouraged to participate in continuing education related to the treatment of these disorders. These may be used to meet the 20 hours of CNE requirement, and each nurse, including APRNs, are required to complete 2 contact hours in nursing jurisprudence and ethics at the end of every third 2-year licensing period. These hours may be used to meet the 20 contact hours of CNE. Certification and or CME may not be used to fulfill the CNE requirement. So that's why I reinforce that you still have to have all these other subspecialty hours in place, even if you meet the requirement for 20 contact hours. Okay, so we are still looking at the continuing education requirements. A nurse, including an APRN whose practice include older adult or geriatric populations, is required to complete at least 2 contact hours of CNE relating to older adult or geriatric populations or maintain certification in an area of practice related to this patient population. So the course must contain specific information related to elder abuse, age-related memory changes, and disease process, chronic conditions, end-of-life issues, etc. So if you're in adult gerontology, acute care, or primary care, as long as you maintain your certification, which you have to maintain licensure, then you do meet this requirement and don't have to necessarily necessarily do anything additional to do that. Now, one thing for everybody to remember is that if you have to maintain national certification in order to keep your license at the state level or in Texas. So, but part of maintaining your national certification requires you to get a number of continuing education hours. So just because the board is comping you 20 hours doesn't mean that you're not going to be doing them. It just means that the board is recognizing that you're doing that to maintain certification. And as long as you maintain certification, they don't have an issue with you. And finally, a nurse, including an APRN who provides direct patient care, must complete continuing education in human trafficking. This course must be approved by the Executive Commissioner of the Health and Human Service Commission. This goes into effect on September 1, 2019, and persons who renew their license on or after September 1st, 2020 will have to meet this requirement. So we're looking at Chapter 217 of the Board of Nursing Rules and Regulations. The title of this chapter is Licensure, Peer Assistance, and Practice. So specifically, Rule 217.7 titled Change of Name and Address. This does require a nurse or the applicant to notify the Board of Nursing in writing within 10 days of the change. A name change must be accompanied by the legal document showing the change. So Rule 217.11, Standards of Nursing Practice. This rule, it's important that you understand, applies to all nurses, LVNs, RNs, and APRNs. This rule describes the standards we are all required to follow. These include understanding and knowing the rationale for medications, their effects, accurate documentation, protecting patient safety and privacy, promoting and participating in education and counseling of the client and family, maintaining professional boundaries, obtaining orientation and training when implementing new procedures or practices, or when encountering new equipment, infection prevention, clarifying orders, and implementing new or mandatory reporting for licensed professionals. There are more items, and you should certainly take the time to read this, but I do want to point out a few specific items that I think are important. And so one, this rule says, provide without discrimination nursing services regardless of age, disability, economic status, gender, national origin, race, religion, health problems, or sexual orientation of the client served. So there is a non-discrimination expectation and requirement from the board that we should all be aware of. Know and conform to the Texas Nurse Practice Act and the board's rules and regulations, as well as all federal, state, or local laws, rules, or regulations affecting the nurse's current area of practice. So this is where they tie us into knowing all the various laws that impact our scope of practice, not just as registered nurses, but also as APRNs. They do require us to implement measures to promote safe environment for our clients and others, and accept only those assignments that take into consideration the client's safety and that are commensurate with the nurse's educational preparation, experience, knowledge, and physical and emotional ability. So we're still in Chapter 217, Licensure, Peer Assistance, and Practice, and Rule 217.14 addresses registered nurses performing radiologic procedures. And in this rule, it says a registered nurse who performs radiologic procedures other than in a hospital that participates in Medicare or that is accredited by Joint Commission shall submit an application for registration to the board. They must submit evidence of the following: that they have a current RN license in Texas, and the name and business and address of the practitioner or director of radiologic services under whose instruction or direction the procedures will be performed. The board does provide email notification of the completion of the registration to the applicant. The RN is required to notify the board of any changes to the registration within 30 days of the change, and must comply with this medical radiologic technologist law, which is found in the Occupational Code Chapter 601, and in the applicable rules in the Texas Medical Board, because they actually write the rules for this particular law. The RN must complete an appropriate training program that adequately adequately prepares the nurse to perform radiologic procedures. They must maintain a record of this training and keep their original certificate of completion for a minimum of 3 consecutive renewal periods. So what this says is if you're doing radiologic procedures, you have to have appropriate, you have to go through an appropriate training program and get that certification completion certificate. So 217.18 addresses assisting in surgery, and this really applies to first assistants. An RN who wishes to function as a first assistant shall meet the following requirements. So they have to have a current RN license in Texas or a compact state. They must complete a nurse first assistant educational program approved or recognized by an organization recognized by the board, and have one of the following: currently certified in perioperative nursing by an organization recognized by the board, are currently licensed in Texas as an APRN. And note that APRNs must function within their scope, and all RNs must comply with the standards set forth by AORN. So that means if you're an APRN, you still have to comply with the standards developed by AORN. Texas Board of Nursing Rule 217.23, Balanced Billing Dispute Resolution. Let me spend just a few seconds describing to you what balanced billing is. Often this happens with providers who are out of network on a patient's insurance. You see this often in emergent situations, in the emergency room, maybe in urgent care, etc. And so what happens is, because they're not in network with the patient's insurance company, they only get a portion of what their fee is for providing care. So what happens, or what has been happening, is that they then balance bill the patient for the amount that was not covered for the by the insurance. So this rule specifically talks about that practice. So that's why you need to pay attention to it. So this rule was developed by the Board of Nursing to implement the requirements of the Insurance Code Chapter 1467. An out-of-network provider may not balance bill an enrollee receiving non-emergency health care or medical service or supply, and the enrollee does not have financial responsibility for a balance bill unless the enrollee elects to obtain the service or supply from the out-of-network provider, knowing that the provider is out of network, and the enrollee may be financially responsible for the balance of the bill. The enrollee must voluntarily elect to receive the service. The enrollee is said to voluntarily elect to receive the service if they have a meaningful choice between an out-of-network provider and an in-network provider. A meaningful choice does not exist if the out-of-network provider was assigned to the enrollee. The enrollee is not coerced by the provider or health plan when making a decision, and the out-of-network provider or their designee provides written notice and disclosure to the enrollee and obtains written consent from the enrollee. The law provides the provider an option to complete a mediation with the insurance company for any unpaid balance of their bill. If the provider chooses not to go through with the mediation and they want to balance bill the enrollee, they must provide a disclosure statement to the enrollee. This statement must be signed by the enrollee no less than 10 business days before the date of service or supply is provided. The enrollee may rescind acceptance within 5 business days from the date the disclosure was signed. The provider must maintain a copy of the disclosure for 4 years that the service was provided and a balance bill was sent to the enrollee. Providers must use the Texas Department of Insurance Form AH025 as the notice and disclosure statement. This form may not be modified in any manner. Providers who seek and obtain an enrollee's signature on the notice and disclosure statement may not go through with mediation. Chapter 221, Advanced Practice Nurses, Rule 221.2, APRN titles and abbreviations. APRNs must be licensed in one or more of the following roles and population foci. So the roles are the Certified Nurse Midwife, the Certified Nurse Practitioner, Certified Registered Nurse Anesthetist, and Clinical Nurse Specialist. And so the population foci are adult GERI, either in acute or primary care, family, which is across the lifespan, neonatal, pediatrics, again, also either acute or primary, psychiatric mental health, women's health, nurse practitioner. So an RN who holds a current license issued by the Board of Nursing as an APRN shall at a minimum use the designation APRN and the APRN licensure title, which consists of the current role and population. So what that means is that as you sign your name or on your badge or on your lab coats, you must have and use in your signature the APRN. You have to identify yourself as an advanced practice registered nurse. If you do not, you could be sanctioned by the board. So while you're working as an APRN, you must wear clear identification which identifies yourself as an APRN and your specific population focus. So if you're family FNP, you should have APRN, FNP behind your name. Once you're licensed, you can't use those titles before you are licensed by the Board of Nursing. Please note that the APRN title is protected and one cannot use that title without being licensed. That's why I say you don't use it before you receive that license from the Board of Nursing. So some of you may be wondering this, so I've included this in the lecture so I could explain. So why are nurse practitioner programs so strict on the type of clinical hours students can perform? I'm going to tell you why. Texas Board of Nursing Rule 221.3 APRN Education and 221.4 Licensure as an APRN helps to give schools guidance as to what we have to do in order to meet requirements for you to be eligible to be licensed in the state of Texas. And so these rules state that one must graduate from an APRN program or a postgraduate program. You must have a current RN license in Texas and it must be unencumbered. You have to hold a national certification. So upon graduation, you have to sit for certification and pass it before you can apply for Texas licensure. You must have had to complete a minimum of 400 hours in the last of clinical practice within the last 2 years. And your clinical hours that you've completed in school do qualify to meet that requirement. You have to have 20 contact hours of continuing education over the last 2 years, and you must have completed a minimum of 500 clinical hours in your school or program. And so it goes on to say that each instructional track and major shall have a minimum of 500 supervised clinical hours as defined by the board. The supervised experience shall have been directly related to the role and population focus area of licensure and include pharmacotherapeutic management of patients. So what it's saying is if you're in an adult geri acute care program, then your clinical hours must be aligned with the scope of practice of the adult geri acute care NP. If you're in a family nurse practitioner program, then your clinical hours must be aligned to that scope of practice of the FNP, which is primary care across the lifespan. So they also require that you must have a separate course in advanced pathophysiology, advanced pharmacotherapeutics, and a health assessment, a role in didactic and clinical courses, and a final practicum preceptorship on your transcripts. The program must be at least 1 year in length. So why does this all matter? This matters because the Board of Nursing controls whether you get licensed or not. And so I want to tell you a story about an incident that just happened that I was aware of, and it shocked me to hear this. So I want to share it with you to drive the point home. So I had a graduate from an out-of-state nurse practitioner program contact me, and she had attended an FNP and an AGACNP program. It was a master's program, and the program prepared her for both roles. So when she graduated, she was able to sit for the FNP certification and the AGACNP certification. So after graduation and after passing certification, she moved to Texas. And she applied for licensure in both population roles. The Board of Nursing only licensed her and only would license her in the FNP role. And the reason they did that was because they required additional information from the school to validate that she had separate clinical hours in the AGACMP role. When they got the documentation from the school, they noted that her AGACMP clinical hours were precepted by family nurse practitioners, and many of her AGACMP clinical hours were in an acute and critical care setting taking care of unstable patients. So when the Board of Nursing saw this, they basically come back and told her she did not meet the minimum 500 hours of requirement because she did about 200 or 300 clinical hours with an FNP taking care of a critically ill patients. And the Board of Nursing says those hours do not count because that FNP was not practicing within their scope of practice. So they have told this licensed and certified, or this certified NP who's graduated and met all of the requirements, that she will, if she wants to get licensed in the state of Texas as an AGACMP, she has to go back and complete around 300 more hours of clinical with an appropriate preceptor. So the reason why we're so strict on all of these requirements is because if we do not meet the need and we don't meet the Board of Nursing requirement, they will not give you a license. You will not be eligible for license, and you would be even more upset with us if that happened. So Rule 221.8 APRN licensure renewal tells us what is required to renew your license, to renew our licenses every 2 years. And so you have to maintain that national certification in your APRN role or population. You have to maintain your Texas RN license. You have to have at least 400 hours of current practice within the last 2 years. And then you have to meet the minimal continuing education requirements in Rule 216. So Rule 212.12 defines the scope of practice. We've already talked about this, but the bottom line is that the board says that scope of practice is defined by the national APRN organizations. And also they say that the APRN scope shall be in addition to the scope of practice permitted in RN. Rule 221.13 titled Core Standards of Practice. This rule really defines for all APRNs in Texas what the minimum standards of practice are for all APRNs. And I said minimum, I'm not sure that it's exactly minimum, but anyway, these are the core standards of practice that we all have to follow on top of all the other rules for registered nurses as well. So in this section of the rules, the Board of Nursing requires the following. So it says that APRN shall conform to the Texas Nurse Practice Act, current board rules, regulations, and standards of professional nursing, all federal, state, and local laws and regulations affecting the APRN role. So here they tie you into, or rather they tie us all into knowing all federal, state, and local laws and all the rules, etc. So the Board of Nursing expects that we follow them, and in order to follow them, we have to know what they are. They say specifically in this rule that we are required to practice within our scope. And then they also say that when providing medical aspects of care, APRNs must work under a protocol or written authorization. So everything that we do as nurse practitioners in the state of Texas, or even APRNs, is a delegated act from a physician. There's not anything that we can do independent of a physician. So if we don't have a current delegation agreement from a physician, there's nothing we can do as an APRN. So the written protocol and written authorization has certain requirements. It says it must be developed by the APRN and the physician together. It has to be signed by both parties. It has to be signed and renewed annually. Must be maintained in the practice setting of the APRN, and must be available as necessary to verify the authority to provide medical aspects of care. This rule also states that an APRN retains professional accountability for advanced practice care. So what this means is if a physician tells you to do something and you are supposed to know not to do it and you do it anyway and you do it, then you are accountable for this. It also means that the physician is not necessarily liable for anything that you do wrong, because you are still responsible for your own care, and so the physician is not necessarily liable just because they are your delegating physician. Rule 222.2 talks about the approval for prescriptive authority, and basically it says you have to have prescriptive authority in order to prescribe or order a drug or a medication. In order to have this prescriptive authority, you must apply for it and meet the licensure requirements of an APRN. In order to renew your prescriptive authority, you have to apply for renewal and meet the continuing competency requirements for pharmacotherapeutics and controlled substances. Rule 222.4 describes the minimum standards for prescribing or ordering drugs and devices. This rule states that we can only order those medications or devices that we are authorized to do so by either a prescriptive authority agreement or a facility-based agreement. It states that we have to basically prescribe within our scope of practice. So again, the board is tying us into a particular scope of practice as it is aligned to our those professional nursing organizations. And it says we must comply with the chart review and face-to-face meetings required in the prescriptive authority agreement or the facility-based agreements. Prescription information these prescriptions that we write have to contain all this information on this. So you need to make sure you read all this and make sure that each and every one of your prescriptions contains all this, because they are required to do that. Waivers for electronic prescribing requirements. Beginning January 1st, 2021, licensed prescribers were required to prescribe controlled substances electronically. This was due to a change in the Texas Controlled Substance Act back in 2019, I believe it was. But there are waivers available for economic hardship or technological limitations. So make sure you have to, if you need a waiver, and if you're in practice and you need a waiver, make sure that you go to the Board of Nursing and apply for that. Otherwise, you are expected to prescribe controlled substances electronically. And then lastly, APRNs may order or prescribe medications for sexually transmitted diseases for partners of an established patient if the APRN assesses the patient and determines that the patient may have been infected with the STD. Rule 222.4 also states a couple more things, and that is APRNs may order or prescribe only those medications that are FDA approved unless done through a protocol. So what this means is that if it's not an FDA approved medication, or it is not indicated for the diagnosis that you want to prescribe it for, you cannot do that. There are some exceptions to this rule, and that is traditionally the research protocol or a standard practice that we see for off-label uses. Often there's the most common medication that always comes to mind when I talk about this is Zofran. We prescribe that all the time in the hospitals for nausea, but it's not really prescribed for general nausea. It's for postoperative nausea and chemotherapeutic related nausea. So that is something that would be an example of this exception to this type of rule. So this rule also states that the APRN with full licensure and a valid prescriptive authorization shall cooperate with representatives of the board and the Texas Medical Board during an inspection and audit relating to operations and implementations of a prescriptive authority agreement. So in Texas, as we've discussed already, APRNs are required to work off of a delegation agreement with a physician. And so in Texas, there are two types that one can choose from to work under. And the first one is prescriptive authority agreement, and Board Rule 222.5 addresses that. The second type is a facility-based agreement, and we'll talk a little bit more about that on a couple slides, but for now we'll focus on the prescriptive authority agreement. And so this is the mechanism by which an APRN is delegated the authority to order or prescribe drugs or devices by a physician. This agreement typically is associated with an outpatient practice, but it can be used on the inpatient side as well as the outpatient side. So if an individual um, works in just an outpatient practice, they have to use the prescriptive authority agreement. If they work in an outpatient and an inpatient practice, so they're doing both, then it's best to use the prescriptive authority agreement because you have to use it for the outpatient, and you can use it for the inpatient side, but you don't necessarily have to. So if an individual is working in a facility-based practice only, then one should just use the facility-based practice. There's a lot less requirements in that we have to follow. So if you're working inpatient only, the facility-based agreement is best. So again, let's refocus on prescriptive authority agreement. This rule requires that the physician and the APRN must disclose to each other if there are any disciplinary actions on either one of their license. There are required elements that one must have in this prescriptive authority agreement. Again, it has to be in writing and signed by both parties. It must state the name, address, and all professional license numbers of the parties in the agreement. The nature of the practice locations, and practice settings must be on here. It must identify either the categories of drugs or devices that may be ordered or prescribed, or the category of drugs or devices that may not be ordered or prescribed. There must be a plan for providing consultation, for addressing consultation and referrals. There has to be a plan for addressing patient emergencies. Additional requirements of a PAA. The PAA must state the general process for communication and sharing of information between the APRN and the physician. If alternate physician supervision is to be used, this must be designated in the PAA. The PAA must describe a prescriptive authority quality assurance and improvement plan and specify methods for documenting the implementation of the plan. The plan must include chart reviews with the number of charts to be reviewed determined by the APRN, and you must meet with your physician to review these charts. The meetings with your physician must include the sharing of information relating to patient treatment and care, needed changes in the patient care plans, and issues relating to referrals. The meetings must include a discussion of patient care improvements, and the meetings must take place monthly in a manner determined by the physician and the APRN. So you can meet with them over the phone, you can meet with them over the internet using audiovisual technology, or you can meet with them in person. APRNs must undergo quality reviews, or APRNs may undergo quality reviews with another physician if it is designated in the PAA. The PAAs must be obtained for 2 years. You must review the PAA with your physician or alternate physicians every year, and it must be signed by everybody every year. And you must notify the physician if you become the subject of an investigation by the Board of Nursing, and likewise the physician must do the same for you. So let's look at a case scenario here. The AGACMP is working for a hospitalist group, and the medical director has delegated authority for the AGACMP to see the practice patients in the hospital. Upon meeting a newly hired physician, Dr. Smith tells the AGACMP, I do not believe in using nurse practitioners to care for my patients. How should you handle this? The answer to this question actually lies in Rule 222.6, prescribing at a facility-based practice. So as I said before, there is one of two ways that delegation can happen from a physician to the APRN. The prescriptive authority agreement is the one way, and the facility-based practice is another way. If you are working in a facility-based practice only, meaning in the hospital or just in a nursing home, then you can use a facility-based practice agreement between you and the physician. And so part of this rule states that the APRN must order or prescribe drugs and devices in a hospital-based facility in which the delegating physician is the medical director, the chief of medical staff or the chair of credentialing committee or department chair or physician who consents to the request of the medical director to delegate. And so that's what's key. It has to be somebody over a supervisory of the physicians, because that physician actually does all the delegation for the other physicians. And so that's a key point to understand when thinking about this scenario, because this last bullet point says the APRN can only order or prescribe drugs or devices for the care or treatment of only those patients for whom physicians have given their prior consent. Because this rule says this in a facility-based agreement, in this particular scenario, if that physician does not want nurse practitioners caring for his patient, you cannot legally see those patients because he has not officially given consent for that, and you kind of have to back off. So to talk about the facility practice agreement a little bit more, bullet point 1 states that APRNs with full licensure and a valid prescriptive authorization number may order or prescribe a drug or device at a facility-based practice under a prescriptive authority agreement or through protocols with authorization developed by the facility's medical staff policies. So you can, in a facility-based practice, use the PAA or a facility-based agreement. If you use a PAA and you're working in the facility-based agreement, facility-based practice, then you have to follow all the quality rules that are in the PAA and follow the monthly meetings with the physician, etc. So the facility-based practice agreements do not have those quality requirements, because usually there are multiple physicians that are seeing patients in the practice in the inpatient setting, so it's not as strict on the inpatient setting. Again, these protocols have to be reviewed annually with the physician, signed by the physician and the APRN, and kept for two years as well. So Rule 222.7 tells us that we have to be licensed and have valid prescriptive authority in Texas as an APRN in order to order dangerous drugs or DME. It's important that you understand this, because you can be licensed as an NP in Texas but not have prescriptive authority, and there are many people who do that if their jobs do not require them to prescribe medications. And so nurse faculty are some of those individuals. If they don't have a practice outside of teaching, then they may not have prescriptive authority. So when you get licensed in Texas, you have to make sure that you check the box saying you want prescriptive authority, and you pay that fee. Rule 222.8 tells us what we're permitted to do when it comes to controlled substances or prescribing controlled substances. This, of course, is a delegated act from a physician. The law allows us to prescribe Schedule 3 through 5 medications. We may only give up to 90 days of medications, and after 90 days, if the person needs additional medication, then we are required to discuss this with the physician and document that in the patient's chart. We are not permitted to prescribe for children under 2 years of age without prior consultation with the delegating physician, and this has to be documented in the chart. So that's particularly important for those of you who are in pediatrics and neonatal or even family to know that you cannot do that. We can prescribe Schedule II medications in certain instances, and one is in facility-based practice, particularly a hospital facility-based practice for patients who are going to be admitted with an intended length of stay or an anticipated length of stay of greater than 24 hours. Then we can prescribe Schedule II medications in that instance. Or if the patient is in the emergency room that is physically attached to the hospital, we can prescribe them Schedule II medications for use while they are in the hospital or in the emergency room. Those freestanding EDs do not qualify for that, even if it is owned by the hospital. So please be aware, if you're working in one of these freestanding EDs, you cannot prescribe scheduled medications. The emergency room has to be physically attached to the hospital. So the other situation in which we can prescribe Schedule II medications are for those patients who are receiving hospice care. So Rule 222.9, conditions of obtaining and distributing drug samples. If you're working in an outpatient practice, there are times where you will have drug samples that the reps will bring by for you. It's rather helpful, and it's definitely a good idea. But in order for us to do that in our practice, it must be authorized in our PAAR or the facility-based agreement that we can order or prescribe medications and collect these drug samples. The samples may only be for drugs or devices that we are eligible to order or prescribe, and we have to maintain a record of these items. And so that record has to comply with all these various laws here. So if you do this, then make sure that you maintain the appropriate record and you look up these various laws to make sure that you are compliant. So let's look at our next scenario. We have an AGACMP colleague that tells you she has an ear infection and has written a prescription for herself to treat the infection. Is this legally allowed? Can an AGACMP write an inpatient order for a patient to receive vancomycin and have pharmacy to dose? Now, again, the example here is AGACMP. This could very easily be an FMP on the outpatient basis or a PMP on an outpatient basis. If they're a PMP, then and the person and the individual is older than 21, which most likely they are, is definitely out of their scope. So that alone would say it's illegal. So just put this in context for your specialty. So what Texas law gives us direction on this? And of course, it's the Board of Nursing Regulations, rules and regulations. So there is the Rule 222.10 enforcement, and this law says any APRN who violates this section of the rules or orders or prescribes in a manner that is not consistent with a standard of care shall be subject to removal of the authority to order or prescribe under this section. So behaviors associated with ordering and prescribing medications for which the board may impose disciplinary action include but are not limited to all of these things here. And so this basically prohibits us from prescribing for ourselves. So no APRN can prescribe a medication for themselves. We cannot authorize another person to order or prescribe or dispense any medications for us. So, and that's the last bullet point here. We cannot delegate that authority to anybody. And so that's where that scenario came from. And so the answer to that for the pharmacist, are we delegating to the pharmacist to prescribe this medication? Ultimately, no, we're not. We are taking an interprofessional approach in that scenario to the management of vancomycin. We've ordered the vancomycin, but we are asking the pharmacist who has far more knowledge about the pharmacotherapeutics and how to manage that and where the trough levels need to be, etc., to manage that medication. And so we're taking that interdisciplinary approach, and that does not really necessarily fall in here. Under this rule, that is. So make sure that you're familiar with these things so that you don't accidentally violate the expectations in this rule. Okay, so we have another case scenario here. A nurse practitioner is employed by a physician to provide primary care services in his office. The physician employs a medical assistant in the back office to assist with checking in patients, obtaining historical data, doing vitals, collecting urine and stool samples, and administration of medication. What is the nurse practitioner's role and responsibilities in the supervision of the medical assistant, and can the nurse practitioner delegate nursing tasks to the medical assistant? So the answer to these questions is not a very easy one, and basically the answer lies in Rule 224 of the Board of Nursing Rules and Regulations, and this is titled Delegation of Nursing Tasks by Registered Professional Nurses to Unlicensed Personnel for Clients with Acute Conditions or in Acute Environments. So this is the delegation rules that apply to all registered nurses, whether we're APRNs or not. And so Rule 2, let me back up. We are responsible for following the delegation rules as outlined by this chapter as APRNs. We are not exempt from this rule. We are beholden to this rule because we are RNs. In Rule 224.1, this rule applies, it states that this rule applies to any APRN who's providing care to a client who has an acute health condition that is unstable or unpredictable, or the client for whom the APRN is providing care is located in an acute care environment where nursing services are continuously provided. Settings include but are not limited to hospitals, rehabilitation centers, skilled nursing facilities, clinics, correctional health, private practice physician offices, and any setting which does not meet the definition of independent living environment in Rule 225.49. So to be clear, again, this rule applies to all APRNs and all registered nurses. So we have to understand what Chapter 224 says in order to answer these questions. So this is, now we know that this applies to all of them. Rule 224.6 gives us the general criteria for delegation, and so this rule states that these following items must be met in order for the RN to be able to delegate a nursing task. So 1, the RN must make an assessment of the client's needs. This should include a consultation with the client if their condition allows and with the family if appropriate. The task must be one that a reasonable and prudent RN would find is within the scope of sound nursing judgment to delegate. The task must be one that in the opinion of the delegating RN can be properly and safely performed by the unlicensed personnel without jeopardizing the client's welfare. Again, that goes back to the standards of practice. We have to promote safe patient environment. The fourth one is the task must not require the unlicensed person to exercise professional nursing judgment. They may take any action that a prudent non-healthcare professional would take in an emergency, though. The rule also requires that the unlicensed person to who the nursing task is delegated must be adequately identified. This may be done by the individual or if appropriate by the training, education, and certification permit of the unlicensed person. For example, medical assistant. The RN shall instruct the unlicensed person in the delegated task or verify the unlicensed person's competency to perform the task. The RN shall adequately supervise the performance of the delegated task, and if the delegation continues over time, the RN shall periodically evaluate, review, and when a change in the condition occurs, reevaluate the delegation of the task. Rule 224.7, titled Supervision, tells us what is required of us as RNs in the supervision of delegating nursing tasks. And so what this rule says is that the degree of supervision may be determined by the RN after evaluating the client's stability, the training and experience of the unlicensed personnel, the nature of the task to be delegated, and the proximity and availability of the RN to the unlicensed personnel. So ultimately, what this rule does say is that the RN supervising the unlicensed person must be available in person or by telecommunications. So we are responsible for supervising these individuals, regardless of whether we're RNs, we're at the RN practicing at the RN level, or at the APRN practicing at the APRN level. We are still responsible for supervising them. So 224.8, delegation of tasks, gives us tasks that are typically okay to delegate to unlicensed personnel. And so what this rule says is that stuff like non-invasive and non-sterile treatments are good, collecting, reporting, and documenting data such as vitals and height and weight and capillary blood glucose collection, urine tests, etc. Those type of things are good. Ambulation, ADLs, transportation, reinforcement of health teaching, those are all appropriate tasks to delegate. The rule 224.8 also tells us what's not appropriate to delegate. And so that includes physical and psychological and social assessment, the formulation of a nursing care plan, specific tasks involved in the implementation of the care plan, and those tasks that specifically require professional nursing judgment or intervention. The responsibility of the client's health teaching or counseling cannot be delegated, and note this last bullet point, and this is what gets most of us in the office setting, is administration of medications, including IV fluids. It is never okay for us to delegate the administration of medications to unlicensed healthcare professionals. That is a nursing responsibility according to the Board of Nursing, and as an RN we cannot delegate that, which is why this becomes difficult in the office setting when you are working with a medical assistant. So the final rule to look at is 224.10, supervising unlicensed personnel performing tasks delegated by non-RN practitioners. In this particular scenario where you're working for the licensed physician, or you're working for the physician has the medical assistant employed, this rule applies to that and gives you guidance on how you are supposed to handle that. And so this rule says it applies to all RNs who practice in a collegial relationship with another licensed practitioner who has delegated tasks to an unlicensed person over whom the RN has supervisory responsibilities. So that is this scenario that we talked about a few slides ago, was the physician is delegating to the medical assistant the administration of medications. And so when you're brought into a practice, that you cannot do that delegation. The physician does the delegation. But what this rule says is that we are still beholden to supervise that patient, and we have to verify that patient's training, or that person's training, the unlicensed personnel's training. We have to verify that they can properly and adequately perform the task, and we have to still supervise that unlicensed person. If there are any concerns that we have regarding their ability to manage these tasks, then we are required to notify the person who's doing the delegation. So you need to keep documentation of these items. If you are working in a practice that has a medical assistant, you need to keep documentation of this. And of course, if the delegation is ongoing, you need to have a regular plan to validate their ongoing competence as well, because you are still required by the Board of Nursing to ensure that these individuals are performing appropriately and safe. And if there are any concerns about safety, then you have to report it to the delegating provider. So just because the physician is delegating the task for you doesn't mean that you are without, or we are without, any responsibility. We do have clear responsibilities here that we have to be responsible for. So how should the MP handle this situation? We've already talked about this a little bit already, but certain tasks we can legitimately delegate as the MP, which is okay. The problem, as I said already, comes with medication administration, and this is the one thing we can't follow. We have to document the person's competence and ensure patient safety. And the Texas Board of Nursing does suggest that the office setting have a job description and policies and procedures in place that clearly delineate who's delegating the authority to the unlicensed professional to function in this matter. And again, you should maintain some documentation of the unlicensed professional's competence. Rule 228.1 is titled Pain Management Standards of Practice. So this is a rule that's particular to APRNs specifically. And so we've got 3 or 4 slides on this rule with all the specifics in it. I am not going to read every slide to you, but I'm providing you with this information so that you know, and I'm just going to give you an overview over these 3 or 4 slides on this particular rule. So this rule says that the goal of therapy is to treat the pain in relation to the health, physical function, and social and work-related factors. So the purpose of pain management, this is not in this rule particularly, but the purpose of pain management is to increase the patient's function, not to eliminate the pain. So you want the patient to be functional, and that's kind of where we're going here. This rule came about from the Board of Nursing because there were a number of nurse practitioners out there prescribing pain medications under a delegation agreement. At one point that did not have appropriate medical diagnoses attached to the prescriptions. And so this is why this whole rule came about, because there was a huge problem with that, and nurse practitioners were being sanctioned by the board for their poor prescribing practices and documentations. And so as you notice, the third bullet point here says that medications must be prescribed in a therapeutic manner that helps rather than harms the patient. It must be appropriate and safe for the diagnosis. So that's where that's where that specific rule is coming from, because of the prescribing practices of nurse practitioners at one point, what they were doing. So when you read this rule, it's important that you read this rule and understand it, because when you read this rule, it reads like it's chronic pain management, but it never says it in the rule, and that's intentional by the Board of Nursing. It is not intended to only reflect care that we provide for chronic pain management. It is intended for acute and chronic pain. So they make no differentiation in here about acute and chronic pain. So we all, regardless of our practice settings, regardless of our population, if we're treating pain, we are all required to follow these rules. And so these rules talk a lot about how we have to do an appropriate assessment, how we have to do appropriate follow-up. There has to be informed consent on the patient's chart for pain management. Drug screening has to be done in the appropriate settings. We have to document all the referrals that we do. We have to document the treatments and the responses and everything that we've done. So there's a lot to this pain management rule that you need to be aware of. In the inpatient setting, how I tend to practice is in my position, I work for a hospital service, as I said, and I tend to admit patients from the emergency room to the ED. And so what I will do, knowing that this rule is here, is I make sure that when I go to admit somebody, if they're having pain and I need to treat it, I ask the patient all those qualifying factors, because we're required to do an appropriate assessment. And so I ask them those qualifying factors about their pain. Where is it? When did it start? Does it come and go? Does it radiate? Is it constant? What does it feel like? Is it a burning or is it sharp pain, etc.? What have you done at home that has helped the pain or not helped the pain? Then I look in the ED records. I see what the ED has done, and I will ask the patient, well, the emergency room physician gave you this. Did it help your pain? What was your pain level before the intervention, and what's your pain level now? And I get all that information and I document that in my note, and then I have the basis to write the basis to meet this rule requirement and write those scheduled medications. So it's extremely important that you know this rule, and that you follow this rule regardless of your practice setting. So this slide and this portion of the rule tells you about the appropriate evaluation of the patient, which is what I just finished discussing. And so this was lacking with a number of NPs who got sanctioned by the board, which is why we have this rule. So you should be familiar with these things so that you document appropriately and you assess your patient appropriately. So this slide talks about the treatment plan and what's required in our documentations and of us when we're treating pain. This slide talks about ongoing monitoring of the treatment plan and what we are responsible for. Again, this talks about referrals and consultations. We have to make the appropriate referrals, and we have to document it. And then the last thing that's really interesting of this rule is that it says that APRNs for pain management clinics, and so this is specifically for outpatient clinics that do pain management, APRNs must be on site with the physician at least 33% of the time. And then they also must review 33% of the patient's chart with the physician. Lastly, there's a note in this rule that says that we as APRNs cannot own or operate a pain management clinic. So let's look at our next case scenario or question. And the question is, can an RN take orders from an APRN who is not working within their scope of practice? And so there's no rule specific to this, but standards of practice 217 would apply here for the RN. But the Board of Nursing does have a position statement on this, and it addresses this actual question. And so what the board says is that the board recognizes that in many settings, nurses and advanced practice registered nurses work together in a collegial relationship. A nurse may carry out an advanced practice registered nurse's order in the management of a patient, including but not limited to the administration of treatments, orders for laboratory or diagnostic testing, or medication errors. A physician is not required to be physically present at the location where the advanced practice registered nurse is providing care. The order is not required to be countersigned by the physician. The advanced practice registered nurse must function within the accepted scope of practice of the role and population in which he or she has been licensed by the board. So in order for an RN to take orders from the APRN must be working within their scope of practice. Otherwise, the RN cannot take those orders. Okay, so we're done with the Nurse Practice Act, the nurse rules and regulations. So we're going to move into the Texas Board of Medicine and their rules and regulations and see what actually they have that governs our practice as APRNs. So let's look at our case scenario. You're an AGA CMP working for an intensivist group who provides telemedicine consultation to services to a rural hospital without an intensivist program, or you're an FNP or a PNP in primary care completing telemedicine primary care visits in Texas. What Texas law rule governs telemedicine practice, and can you do this? This law is found in the Occupational Code. It provides the authority to the medical board to make rules regarding telemedicine. A treating physician or health professional who provides or facilitates the use of telemedicine, medical services, or telehealth services must obtain informed consent prior to providing the services. So they have to get that informed consent from the patient. They must ensure patient confidentiality. A valid patient-provider relationship exists as long as the practitioner complies with the standard of care. At one point, that was not the case, but it is now because the laws changed over a major lawsuit that happened in about 2017-ish, I believe. The visit may be a synchronous audiovisual interaction between the practitioner and the patient. The visit may be asynchronous using store and forward technology in conjunction with synchronous audio interaction between the practitioner and the patient. The practitioner must provide guidance on appropriate follow-up care, and if the patient consents and has a PCP, the practitioner must provide the records or a report to the PCP within 72 hours. And then one cannot prescribe a drug used for abortion via telemedicine services. So Senate Bill 1107 passed in May 2017 changed the telemedicine laws significantly, and the medical board prior to that had made really strict rules that impeded telemedicine significantly, and so they ended up in a lawsuit with a large telemedicine company, and I think before the lawsuit was actually settled or resolved, this bill had already passed, so it took away everything that that was controversial, and the medical board changed the rules accordingly. So in their current rules, they say that all physicians using telemedicine services shall adopt protocols to prevent fraud and abuse through the telemedicine medium. Physicians must provide patients with their privacy practices if they communicate with the patient with any electronic means other than telephone or facsimile. A licensed practitioner, that's us, is expected to meet the standards of care and demonstrate professional practice standards and judgments consistent with all applicable statutes and rules when issuing, dispensing, delivering, or administering a prescription medication as a result of telemedicine medical services. So that's where we're tied into this. Basically, it's telling us we have to meet the same standard of care. The treatment of chronic pain is not permitted through telemedicine, but acute pain can be done unless it's prohibited by federal law. And then health professionals providing healthcare services or a procedure via telemedicine is subject to the same standard of care as in any setting. Your AGACMP colleague calls you to discuss scope of practice. He's working for an intensivist group and just recently started the position. He is expected to make rounds on ICU patients during the day. The physicians and their MP split the patients and provide care to only their team of patients. The physicians are available for consultation but do not routinely see the patients the MP sees. An FNP, PNP, or NNP is seeing patients in the office without the physician present multiple times a week. What Texas law rule gives us direction for this scenario? What other agency policies must be considered? Is this appropriate? Is this within the scope of practice? So the answer to these questions are on the next slide, but there is a medical board rule that gives us direction on this, and we'll discuss that next. What other agency policies must be considered? So it's the hospital policies that have to be considered, or the organization's policies if it's a large organization. Do they permit this? Most of them will permit this, so it shouldn't be an issue. Is it appropriate? Ultimately, yes, it's appropriate, and it is within the scope of practice. So let's see why. So the medical board rule, standing delegation orders, chapter 193, it says a multitude of things, but this is what gives us direction on those questions. And so this rule number 1 says that a physician is not liable for the act of a PA or an APRN solely on the basis of having signed an order, a standing medical order, or a standing delegation order, prescriptive authority agreement, or other order or protocol. This law states that the physician may not delegate to more than 7 APRNs or PAs total, and that this rule, the limit does not apply to areas that are serving medically underserved population or a facility-based practice. The physicians cannot delegate at more than 1 hospital or more than 2 long-term care facilities. And so this next bullet point is what gives us information about these particular scenarios. And physician supervision of the prescribing and ordering of a drug or device shall conform to what a reasonable, prudent physician would find consistent with sound medical judgment, but may vary with the education experience of the APRN or PA. A physician shall provide continuous supervision, but the constant physical presence of a physician is not required. So that information right there tells us that regardless of the practice setting, that those scenarios are appropriate and are okay. So the other thing that this chapter says is that it requires a physician to report to the board who they are delegating prescriptive authority to. And so this is done electronically through the board's website, and we are all required to do it. And what happens is that when you graduate and you get your license, and then you get prescriptive authority, and you have your first job and your physician, then your delegating physician, you have to go to the Texas Medical Board website. You have to open up an online account. You have to request approval for delegation of of dangerous drugs and controlled substances, and then the physician will open it up and approve it on their end, and give you dangerous drugs and or controlled substances. So it's important that you understand what the difference between dangerous drugs are and controlled substances. Dangerous drugs are everything that's not controlled. That's your blood pressure medicines, your lipid medicines, all of those stuff. Your controlled medications are, of course, your benzos and your opioids, etc. And so the physician has to give you approval for each one individually, and you need to know the difference, because sometimes physicians will not give you dangerous drugs because they don't want you prescribing dangerous drugs based off of the name of it. And so you have to tell them, well, no, dangerous drugs are everything that's not a controlled substance. So you may have to correct them. I've had to do that a couple of times, so you have to know the difference between those two. Okay, so let's look into how the Texas Board of Pharmacy regulates our practice. How does the Texas State Board of Pharmacy regulate APRN practice in Texas? Well, it mandates the prescription of dangerous drugs must be in compliance with all state and federal regulations. State Board of Pharmacy rules are as follows. The Texas Administrative Code, Title 22, Part 15, Chapter 315 on controlled substances went into effect on September 1 in 2016. This requires the use of an official prescription Texas form or an electronic prescription to prescribe Schedule II medications. APRNs and PAs may order official prescription forms from the Texas Board of Pharmacy if a physician has delegated the prescription of controlled substances as allowed by law. Upon withdrawal of the physician's delegations, the PADs are void and must be returned to the Texas State Board of Pharmacy. APRNs and PAs can order the official prescription forms from the Texas State Board of Pharmacy. The order must be signed by the APRN or PA and the delegating physician. And then this rule also requires that NPs and PAs only use official prescription forms issued with their name, address, phone number, and DEA numbers, and the delegating physician's name and DEA number. This rule also goes on to say that a DEA is required. The Board of Nursing rules say that, federal law says that, so it's just a repeat of all that. It does say that the use of official prescription forms are not required for patients who are admitted to the hospital. Because there were changes in the Texas Controlled Substance Act, the Board of Pharmacy rules did change a little bit too to coincide and abide by the law. And so for electronic prescribing, a practitioner must prescribe all controlled substances 2 through 5 using electronic prescriptions. Waivers are available and must be applied for. So as APRNs, you would apply for a waiver if needed through the Board of Nursing. This rule also requires controlled substances prescriptions may not be backdated, so that would be inappropriate. And then also there's a limit for the treatment of acute pain to a 10-day supply of opioid medication, and it may not include a refill. This does not apply to an opioid that is prescribed for the treatment of a substance addiction. So lastly, the State Board of Pharmacy rules. The Board of Pharmacy is responsible for running a prescriptive monitoring program. This started in September 2016, and we are all mandated to check this program before prescribing certain medications. And the purpose of the program is to establish a secure online database to assist healthcare and law enforcement professionals to identify potential prescription drug abuse issues. And this is really controlled substances. You must be registered with the Board of Pharmacy in order to get access to this database. So one of the things that you are obligated to do upon graduation, once you have your prescriptive authority and your DEA, is to set up access to this, because what we'll see a little bit later is that we are required to check this before we order certain medications. Okay, so let's look at specifics in the Texas Health and Safety Code. So we have three case scenarios here. We have a patient with terminal cancer that comes to see you, the NP. He is going on hospice and asks you to sign an out-of-hospital DNR document. Can we do that? A patient is admitted to the hospital and has an out-of-hospital DNR order. The patient and family request the patient to be a DNR. Can the NP write the order? And an AG-ACNP is coding an adult patient. Now this could be a pediatric acute care NP that's coding a patient. The code has been running for the maximum time. For an adult it's 20 minutes, but so it's a little bit over, but if it's a pediatric patient, that time may be less. So let's say that you've gone the maximum time of coding a patient. How should the NP proceed? Can they make the decision to stop? And so this scenario would apply to NNPs as well, and across the board, so to other NP specialties. So the answers are really found in the Advanced Directive Law, and before we answer these specifically, there's a number of things in the Advanced Directive Law that you should be aware of. This law says that witnesses must be a competent adult. One witness must not be related to the person by blood or marriage, cannot be the treating physician, cannot be an employee of the healthcare facility. And so there's information, again, about who's an appropriate witness that we have to know about and follow. The law states that a physician, healthcare facility, or provider cannot require one to execute an advance directive as a condition of issuing insurance or obtaining healthcare services. Sometimes there can be conflicts between advance directives, and so the law states that the one that was executed with the later date in time is the controlling one. The desire of the patient can override the directive at any time. And so the law talks about a procedure when a person has not executed or issued a directive and is incompetent or incapable of communication. So this is important to know because it mandates certain stuff be done by a physician and not by the nurse practitioner. So a patient who is incapable of communicating due to physical or mental means or is incompetent and does not have an advance directive, the attending physician and patient's legal guardian or an agent under a medical power of attorney may make a treatment decision that may include decision to withhold or withdraw life-sustaining treatment. If the patient does not have a legal guardian or an agent under a medical power of attorney, the attending physician and one person, if available from one of the following categories below, may make a treatment decision that may include a decision to withdraw or withhold life-sustaining treatment. A treatment decision made under this portion of the law must be documented in the medical directory and signed by the attending physician. So as you can see, there are obligations or requirements of the attending physician in these instances to meet. So if you're ever in a situation like this, you cannot do these things. It is the physician that has to do this. If a next of kin or medical power of attorney are not available, the attending physician, any physician not involved in the patient's care, can make treatment decisions. So that's where this is where we get the two physician can sign an informed consent type of thing. So this next slide answers one of our first questions, or one of our questions. So the patient certification and prerequisites for complying with a directive. So this portion of the Advanced Directive Law says before withholding or withdrawing life-sustaining treatment from a patient, the attending physician must determine if the steps proposed are lawful and are consistent with the patient's existing desires. So with this, what are the implications on the inpatient setting? And the implications are really come to a couple of things. As one, we cannot make the decision to withdraw care. And so if we are coding a patient and it's gone on for too long, that patient's receiving artificial and life-sustaining artificial care, artificial life support. And so we are maintaining life for that patient by running the code, but we cannot make the decision to stop that because based off of this language in this law, the physician must make that determination to withhold or withdraw life-sustaining care. So we can't withdraw care is the bottom line, and that goes for a code situation or a person who we know is in a medically futile state. So the next portion of the law addresses the procedure for not effectuating a directive or treatment decision. If a physician does not want to follow the directive, the decision should be reviewed by the ethics or medical committee. We have to give life-sustaining treatment during the review and then set up for transfer to a different physician or facility if the committee disagrees with the physician's condition or decision. So continue with Chapter 166, Advanced Directives. This law also says that we cannot withdraw or withhold life-sustaining treatment from the pregnant patient. It does specifically say that mercy killing is not condoned or permitted. And here's the answer to our next question, and that is out-of-hospital DNR orders. This applies to the following settings. So long-term care facilities, inpatient hospice facilities, private homes, hospital outpatient or emergency departments, physician offices, and vehicles during transport. And so the law requires that a physician sign this form, so APRNs are not allowed to sign this form. If the patient is incompetent but has an advance directive, the physician may rely on the directive to issue an out-of-hospital DNR order. So this chapter talks about medical power of attorneys as well, and it says that a medical power of attorney may not consent to a voluntary inpatient mental health service, convulsive treatment, psychosurgery, or abortion. So some general provisions of do not resuscitate orders. And this applies to the inpatient setting. So what was happening a while ago was that physicians were writing DNR orders even when the patient or the family disagreed. And so this law changed, I want to say in 2017, where this new law came out and addressed DNR orders on the inpatient setting. And so that's what this is pertaining to. The bottom line with this addendum to the Advanced Directive law is that only a physician, the attending physician, can write an order for a DNR in the inpatient setting. We are not permitted to write that order as nurse practitioners or any APRN, and this law does hold us accountable, though, for notifying the patient and or the family, the next of kin or the power of attorney, that a DNR order is on the chart. And so the physician can revoke the DNR order at any point. So that does not mean that we as APRNs can revoke it. It has to be revoked by the physician. And so so if a patient tells you that they no longer want to be DNR, you can't even discontinue that DNR order. It has to be done by the physician. So what you would do is notify the physician, let the physician write the order to discontinue the DNR order. I suppose that it could be done through a verbal order. If you talk to the physician tells you, okay, go ahead and write an order to discontinue it, then I would say in my note, I talked with Dr. So-and-so, he ordered to discontinue the DNR, and I've written the verbal order, and it would need to be co-signed by the physician. So chapter 171 of the Health and Safety Code titled Abortion. So our case scenario, we have an FNP, or a women's health nurse practitioner or certified nurse midwife, who just moved to Texas from California. In California, they were trained to perform abortions by aspiration technique. They have informed their current employer that they are trained to do this procedure and have offered their skills to assist with the patient load. Is this permitted by Texas law? Well, the bottom line is in this chapter that this is not a permitted activity in Texas law, and that no APRN can do this. The abortion is strictly a physician only activity. So let's look at a case scenario, and this is related to Chapter 193, death records. An AGA-CMP or an FMP is working for a cardiologist's office. This could very easily be a pediatric MP as well. The office manager asks them to complete and sign a death certificate on a patient who died last night secondary to cardiomyopathy. The physician is on vacation for 2 weeks and the family needs the certificate completed for the life insurance company. Is this permitted under Texas law? And as of June 2021, the law was changed to allow APRNs and physician assistants to sign death certificates. So APRNs began being able to sign death certificates as of September 1st, 2021. So this was not always the case, but it is now the case. Chapter 313, Consent to Medical Treatment Act. Let's look at our next case scenario. You are an FMP, an adult gerontology acute care, adult gerontology primary care MP who is caring for a new patient in a nursing home who is in a persistent vegetative state. She is transferred to the nursing home from the hospital and has no family. So who is legally allowed to provide consent for this patient, and what is mandated by Texas law in regards to obtaining informed consent, should it be needed? And so the Consent to Medical Treatment Act gives us that information, and this law applies to adults 18 and over who are patients in a home or a community support service agency, a hospital or nursing home, or an inmate in a county or municipal jail, and is comatose, incapacitated, or otherwise mentally or physically capable of communication. Those who may consent for this individual are listed in the order of priority. Certainly, the first would be the patient's spouse, an adult child who has the waiver and consent of all other qualified adult children, a majority of the patient's adult children reasonably available, the patient's parents, or a person clearly identified to act for the patient by the patient before they become incapacitated, the patient's nearest living relative, or a member of the clergy. So surrogate decision makers may not consent to voluntary inpatient mental health services, electroconvulsive treatment, the appointment of another surrogate decision maker. For inmates, the surrogate may not consent to the following psychotropic medications, involuntary inpatient mental health services, and psychiatric services. According to this law, if the patient is unable to consent and needs treatment, the attending physician must do the following. So again, we cannot do this as an APRN. The attending physician has to do these things. And so they must document the comatose state, the incapacity, or other mental or physical inability to communicate in the patient's medical record. They have to document the proposed medical treatment in the patient's medical record. The attending physician must make an effort to contact or cause to be contacted or to contact the persons eligible to serve as a surrogate decision maker, and record the date and time a surrogate decision maker consents to the treatment in the chart. The surrogate must countersign the chart or complete an informed consent. So Chapter 322, Use of Restraints and Seclusion. We have an AGA-CMP who is asked to write an order for restraint in the hospital setting, or an FMP that's asked to write an order for restraint in a long-term care facility. Are these appropriate actions for either to complete? And the quick and the short of the answer is no, it's not. It's not permitted by state regulations. So let's see why. So Chapter 322 of Health and Safety Code, titled Use of Restraints and Seclusion, addresses this, and it outlines the following, or it says the following. The restraints can't obstruct the airway, including a procedure that places anything in or on or over the mouth or nose, cannot impair breathing by putting pressure on the torso, cannot interfere with the person's ability to communicate. A prone or supine hold may be used if it is the last resort, or other less restrictive interventions are ineffective, or the hold is used only as a transitional hold. A RN other than one that initiated the restraint, who is trained to assess medical and psychiatric stability and demonstrated competence with completing face-to-face evaluation of a patient in the hospital or facility, must evaluate the patient 1 hour after initiation of the restraints. We have to The physician then must see the patient and do a face-to-face within 24 hours and document the clinical justification for continuing the restraint or seclusion. The codes are the rules are written by the Texas Department of Health and Human Services, and they go on to detail a number of things. And so what we just finished discussing was the law, and so the rule is next. And so the rules say that only staff authorized by the facility's policies and procedures and who have done the specific training can work with the restraints or initiate the restraints. Only a physician, RN, or PA may initiate a restraint or seclusion under the physician's delegation. Only a physician member of the facility may order a restraint or seclusion. So that is the key there. Only a physician can order it. So they have to order it. Any telephone orders given by the physician must be signed within 48 hours, and a face-to-face must be completed within 1 hour of seclusion. A lot of these rules come from the Medicare. These rules come from the Medicare regulations. So if the RN does the face-to-face, they must consult with the physician as soon as possible and, of course, document the consultation. So this is a copy of the law, or the rules, excuse me, and there are time restraints that one must follow for using the restraints, and that's what's located on this screen. So lastly, about the restraints, Rule 415.262 requires that family be notified that a patient is being used for restraints. And then one thing to note is that this rule refers to mental health services, but the law does not specifically say that this only applies to like psychiatric services. Ultimately, these rules should be followed for any restraints used in any licensed hospital or facility. So let's look at our next case scenario. A psychiatric mental health NP is providing care for patients in an inpatient substance abuse treatment facility. An adult patient is suicidal, aggressive, making threats to the staff, and experiencing acute withdrawals from heroin. He is refusing medications to help alleviate the withdrawal symptoms. The psychiatric mental health NP is called to deal with the situation. How should they proceed? Well, Chapter 462 of the Health and Safety Code, which is titled Treatment of Persons with Chemical Dependencies, tells us what we can and cannot do, really what we can't do in this situation. And so what it says, this rule really has physician-only language in it, and this law particularly states that a patient is able to refuse a medication, therapy, or treatment unless they're younger than 18 years of age and the parents have consented, the patient has been adjudicated to be incompetent, or a physician treating the patient determines that the medication is necessary to prevent imminent serious physical harm to the patient or to another person, and then the physician has to write an order or verbal order reflecting that and saying that they can't refuse the medication. So in this instance, if this situation is deemed to be to cause imminent danger to the patient, then the psychiatric NP would have to contact the physician and let the physician deal with the issue and get orders from the physician, because this law does not permit any APRN to override a patient's free will. So note that if the physician should order the medication under the above circumstances, they must document in the medical record the specific medical and behavioral terms for the reasons for writing this order. Okay, so on to the next law in the Health and Safety Code, and that's Chapter 481, Texas Controlled Substance Acts. So how does the Texas Controlled Substance Act govern NP practice in Texas? Well, I'm going to tell you. So this law requires that controlled substances only be prescribed, ordered, or dispensed administered by a practitioner for a valid medical purpose in the course of medical practice. Anabolic steroids or growth hormone may not be prescribed by a practitioner for the purpose of bodybuilding, muscle enhancement, or increasing muscle bulk or strength to a person who is in good health. The law also authorizes the development and the use of the prescriptive monitoring program, which is what is regulated by or controlled by the Texas Pharmacy Board. In 2017, House Bill 2561 was passed, which amended the Texas Controlled Substance Act and imposed more licensing board oversight of the prescription of controlled substances. It requires licensing boards to publish guidelines on the responsible prescribing of opioids, benzodiazepines, barbiturates, and carisoprodol. The Board of Nursing is now required to monitor the information in the prescription monitoring program to identify any potentially harmful prescribing practices and act accordingly. And that means if they see something concerning, they will question you and can potentially sanction you. APRNs are now required to check the prescription monitoring program prior to prescribing one of these categories of drugs unless the patient has cancer, sickle cell, or is in hospice care. Any prescriptions written for pain for a cancer patient, sickle cell patient, or hospice patient must clearly document on the prescription and in the medical record that the patient has cancer or is receiving hospice care. Violation of this is grounds for disciplinary actions. One may not be held accountable for not checking the prescription monitoring program if they have made a good faith effort to do so and are unable to check it for reasons out of their control, such as the website is down. Just make sure that you document that you've checked it and that it was down before you did. So how does this affect inpatient practice? Well, there is a difference between working inpatient and outpatient. On the inpatient side, one is writing an order. They are not prescribing. So technically, you do not have to check this before writing an order for one of these 4 medications. However, there are 2 things I want you to think about. Upon discharge, if you're writing a prescription for opioids, benzodiazepines, barbiturates, or carisoprodol, then you would need to check the prescription monitoring program and put all the documentation in place. So document the reason, document it in the medical record. The other time you might want to look in the prescriptive monitoring program for an inpatient is if there is drug-seeking behavior. In that instance, you would want to check the prescriptive monitoring program to see if there's any patterns in there that can help identify problems with drug-seeking behavior. Again, that portion is not mandatory by the law, but it is a good standard, and any reasonable person would do that. So be aware of that. House Bill 2174 was passed in the 2019 legislative session, and it amended the Texas Controlled Substance Act. It requires that all controlled substances be prescribed electronically. In an emergency, the prescription may be given orally or telephonically, but it must be followed by an electronic prescription no later than 7 days after the oral or telephonic prescription was given. Written prescriptions may be used in the following instances. 1, by a veterinarian. 2, in circumstances in which electronic prescribing is not available due to temporary technical issues. 3, the prescription will be filled in a pharmacy outside of Texas. 4, when the prescriber and dispenser are in the same location or under the same license. 5, for a drug that the FDA requires more information and the information cannot be put on the electronic prescription. 6, for a drug under research protocol. 7, the prescriber determines that the electronic prescription would be impractical for the patient to obtain the drugs prescribed in a timely manner and the delay would impact their medical condition. 8, if the prescriber has a waiver from using the electronic prescription form. Please note that each licensing board has developed criteria for waivers, and they include economic hardship and technical limitations. And then lastly, for any prescription written prior to January 1st, 2021, an electronic prescription is not required. This bill also brought with it more continuing education requirements, and it says a person licensed to prescribe controlled substances are required to complete 2 hours of professional education related to approved procedures of prescribing and monitoring controlled substances. One may take this course annually to fulfill the ethics education requirement of the person's license, certification, or register. This, however, is a one-time requirement. And then lastly, this bill has opioid prescription limits, and it says that opioids prescribed for acute pain management may only be prescribed for a maximum of 10 days or provide for one refill. This does not apply to an opioid approved by the FDA for the treatment of substance addiction that is being used in that manner. Okay, so let's move on to Chapter 489, Access to Investigational Treatments for Patients with Terminal Illness. Our case scenario: a male patient presents to your oncology clinic for follow-up. He has been receiving treatment for metastatic colon cancer and has not had any improvement from standard therapy. All options have been exhausted. He read about an investigational therapy that sounds promising and asks you about getting him the therapy. How should the NP proceed? So Chapter 489 actually addresses this, and it says that a patient is eligible to access and use investigational drug, biologic product, or device if the patient has a terminal illness attested to by the patient's treating physician and the patient's physician in consultation with the patient have considered all other treatment options currently approved by the FDA and determined that those options are not available or are unlikely to prolong the patient's life, and has recommended or prescribed in writing the patient use a specific class of investigational drugs, biologics, or products. So in this instance, ultimately the physician has to do the consultation and documentation, so the NP would need to consult with the physician and have the physician see this patient. Chapter 671, Death and Disposition of the Body. So we have another case scenario, and it's very similar to, it is exactly what a previous case scenario was, and basically we're coding a patient and have reached the maximum time. So you're either an AGA CMP or a PMP in acute care and working for an intensive service, and you're coded the patient for the maximum amount of time. How do you proceed? Or you're an NMP and have been coding a neonate for 15 minutes. Usually the maximum amount of time in neonates is around 10 minutes. So how do you proceed? Can we pronounce death in this instance? And so let's take a look here at the death and disposition of the body law. And so this law specifically gives us some direction, and it says that a person is dead when, according to ordinary standards of medical practice, there's irreversible cessation of the person's spontaneous respiratory and circulatory functions. So it all goes on to say that if artificial means of support preclude a determination that a person's spontaneous respiratory and circulatory functions have ceased, the person is dead when, in the announced opinion of a physician, according to the ordinary standards of medical practice, there is irreversible cessation of all spontaneous brain function. Death occurs when the relevant functions cease. So that language right there tells us again that we cannot make a determination of death when artificial means of life support are being given. When we are coding somebody, we are giving them artificial means of life support. So if we've reached the maximum amount of time that we can code somebody, then in order to stop that code, we're saying that the patient is dead. Well, we can't say that they're dead because the law doesn't permit us to pronounce death in an instance where artificial means of life support is being used. So that's very important for you to understand that. And so remember, in this situation, we can't withdraw care based off the advance directive law either. And so in order for us to stop the code, we would have to be able to withdraw the care, and we would withdraw care by saying they're dead. And so we can't do either one of those actions. So in these instances, the NP, regardless of which specialty type, has to get on the phone or get and consult with the physician and get orders from the physician to stop the code. So that's the bottom line here. We can pronounce death when, if the policies of the facility allow us to pronounce death, but it cannot be on someone who is who is receiving any type of artificial life support. So next case scenario, removal of body parts or body tissue and corneal tissue. So what does Texas law mandate when it comes to the removal of body parts, body tissue, or corneal tissue? So this law really addresses releasing the body and these body parts on a medical examiner case. And basically, if they are an organ donor, no one can make the decision to release those organs except a physician appointed by a county judge or the county judge or justice of the peace. So just be aware if you're ever in that situation that you cannot do that. So let's look at some Texas nursing home rules. So we have a case scenario, an AGACMP or an AG primary care MP or an FMP is working in a nursing home caring for Medicaid patients. What does the law rules say regarding MP visits in the nursing home? And so the Department of Aging and Disability Services writes the rules for nursing home licensure and Medicaid certification. So a Texas Administrative Code Title 26, Part 1, Chapter 554, Subchapter M, Physician Services, specifically describes what the physician's responsibilities are in a licensed nursing home and a Medicaid certified nursing home, and what the APPs, or the advanced practice providers, responsibilities are. So to begin with, this rule states that physicians must approve in writing a recommendation for an individual to be admitted to a facility. So the physician has to write the admission order and sign it. Medical care must be supervised by an attending physician, and another physician must supervise the medical care of a resident when the resident's attending physician is unavailable. The rule also describes how often physician visits must occur. And so the physician must review, revise, and sign orders relating to the resident's total program of care, including medications and treatment. The physician must write, sign, and date progress notes at each visit. The physician must sign and date all orders with the exception of influenza and pneumococcal vaccines, which may be administered per physician's standing order after an assessment for contraindications. And the physician must write, sign, and date physician's discharge summaries within 20 working days. So frequency of the physician visits in licensed facility is also defined, and in this instance, each resident must have an annual exam by their physician, and orders must be reviewed every 60 days unless the physician specifies in writing in the resident's record a different schedule for review and revision. The rule mandates that this annual visit has to be completed by a physician personally. So this is not something that a nurse practitioner or an APRN or a PA can do. So there are different rules for the physician visit frequency in a Medicaid and Medicare certified skilled nursing facilities. So in this instance, physicians must visit the resident at least once every 30 days for the first 90 days after admission and at least once every 60 days thereafter. A visit is considered timely if the visit is completed within 10 days of the required date of the visit. Medicare skilled nursing facilities. In this type of facility, the physician has to do the initial visit, but then afterwards the resident visits may alternate between the physician and the nurse practitioner, CNS, or PA. Certification and recertification in Medicaid certified facilities. The physician must certify the patient's needs for a facility no later than 20 days after admission and recertify the need for a nursing facility every 180 days thereafter. So there are rules about what a physician can delegate as far as what an APRN or a PA can do. And in Medicare facilities, the physician may delegate tasks to an APRN or PA who is acting within their scope of practice and is under the physician's supervision. And then the physician may not delegate a task when state law or regulations require that it be completed by a physician. In Medicaid certified facilities, any required physician task may be satisfied when performed by an NP, a clinical nurse specialist or a PA who's not employed by the facility, but who's working in collaboration with the physician. Now, the nursing home rules and regulations also have specific requirements regarding psychoactive medications. And so they state that psychoactive medications may not be prescribed for any resident without the consent of the patient, or if the patient is not able to give consent, the person authorized by law to give consent for the patient. The exception is if the patient is having a medication-related emergency, and then the necessity of the order has to be documented in the medical record. Psychoactive medications include antipsychotics, neuroleptics, antidepressants, mood stabilizers, anti-anxiety agents, sedatives, hypnotics, and psychomotor stimulants. Informed consent must be in writing and in the patient's chart and include the condition being treated, the beneficial effects of the medication, clinically significant side effects and risk associated with the medication, the proposed course of the medication, and then a refusal to consent to the use of psychoactive medications must be documented in the chart. Let's take a look at this case scenario and how it applies in the nursing home in the state of Texas. We have an AG, primary care nurse practitioner, or FNP, who is working in a nursing home and has a 3-year-old girl with severe cerebral palsy who is a total care patient on their service. Are they permitted to see the patient? Well, the nursing home rules and regulations state that appropriate pediatric consultative services are required to be used. A pediatrician or other physician with training or expertise in the clinical care of children with complex medical needs must participate in all aspects of medical care. The physician extender providing care to a pediatric resident must have training and expertise in the care of children with complex medical needs. For the AG primary care NP, the age alone would prevent them from seeing this patient, and they are not trained to care for children with complex medical needs. For an FNP, it is likely out of their scope as well, as they are not trained in the care of pediatric patients with complex needs. Pediatric programs provide this content in this area specifically, so this is really more appropriate for a pediatric nurse practitioner, whether primary care or acute care, to care for this patient. So let's look at the Texas Transportation Code. And so our case scenario, patient's being prepared for discharge from the hospital. He asks the AGA-CMP to sign the application for renewal of his disability placard. A 60-year-old female with progressive multiple sclerosis comes to your office and has issues with mobility. She asks you to sign the application to obtain her initial disability placard card. So in which scenario is the NP permitted to sign the disability placard application? And so it would be the second scenario. And the law is found in the Transportation Code, Chapter 681, and it allows us to sign the initial certification or the initial application for a disability placard card, but it does not allow us to sign for renewals. So let's look at the occupations code. We have an AGA-CMP who's just graduated with their DNP. She plans to introduce herself to her patients as Dr. ABC. Is there a law that governs this? Can she do this? And the answer is yes, there's a law that governs this. It's Chapter 104, titled The Healing Arts, and it defines who may use the doctor, surgeon, physician, podiatrist, etc. designation. And it states if you're a doctor, then you must designate the healing arts you're licensed to practice, and a person who is not a physician who uses the term doctor must designate the authority under which the title is used or the college which gives rise to the degree. So you can't just say I'm Dr. Gonzalez and leave it alone. You have to say I'm Dr. Gonzalez, an adult acute care nurse practitioner, and make it very clear that you are not a physician, that you are a nurse practitioner. In case you didn't know, Texas does have a compassionate use law that allows certain physicians to prescribe low-dose THC to certain patients. And so our case scenario is you're an AGA-CMP working for a neurology practice. A patient with intractable seizures comes in for follow-up and asks about being prescribed cannabis to assist with his seizures. How should the AGACMP or any MP in this scenario proceed? So Chapter 169, authority to prescribe low THC cannabis to certain patients for compassionate use, is the law that allows this. And it states that only a physician qualified as a provider to prescribe low THC cannabis may prescribe this for intractable epilepsy or other conditions that are identified by the law. In order to do so, they must be licensed to prescribe THC. They must dedicate a significant portion of their clinical practice to the evaluation and treatment of the patient's particular medical condition, and they must be board certified in the medical specialty relevant to the treatment of the patient's particular condition. So in order for a patient to qualify for the getting low dose THC, the patient must be a permanent resident of Texas. The physician must comply with the registration requirements of the state of Texas. The physician must certify that the patient has one of the following diagnoses: epilepsy, seizure disorder, multiple sclerosis, spasticity, ALS, autism, terminal cancer, and incurable neurodegenerative disease. The physician must also determine that the risk of the using low-dose THC cannabis by the patient is reasonable in light of potential benefits. So ultimately, any nurse practitioner cannot prescribe this in the state of Texas, and they must refer the patient to an appropriate physician to get this medication. Okay, let's look at the Texas Education Code. Our case scenario: you're an FNP or a primary care pediatric MP working in a primary care clinic, and the parents bring in their 15-year-old son for you to clear them to return to school sports after sustaining a concussion. How should the FNP PMP proceed? So the answer is in Chapter 38, Health and Safety, in the Education Code. And this code requires schools in Texas to appoint a concussion oversight team. They're responsible for developing a return to play protocol based on peer-reviewed evidence for a student's return to interscholastic athletics, practice, or competition following a concussion. The team must include one physician and one or more of the following: either an athletic trainer, an APRN, neuropsychologist, or PA. Each member of the team must have training in the evaluation, treatment, and oversight of concussions at the time of appointment, and a physician, coach, licensed healthcare professional may remove a student from play if they believe the student has sustained a concussion during practice or competition. So according to this law, a student may be cleared to return to practice or competition when the following have been completed. 1, the student has been evaluated using established medical protocols based on peer review evidence by a treating physician. So this alone does not allow the MP to do that. The student has successfully completed each requirement of the return to play protocol. The treating physician has provided a written statement indicating that in the physician's professional judgment, it is safe for the student to return to play. The student and student's parent or legal guardian have acknowledged the student has completed the requirements of the return to play protocol, have provided the physician release to the school official responsible for compliance with the return to play protocol, and have signed an informed consent consenting to the return to play, explains the risk associated with the student returning to play and will comply with the ongoing requirements, consents to disclose the physician return to statement recommendations to appropriate people as defined by HIPAA, and understands the immunity provision of this law. So let's look at the Texas Labor Code. So Texas Workers' Compensation Benefits, Chapter 408 of the Labor Code. What do you need to know as an APN working with Texas Workers' Comp laws is that it's very, very complicated. If you don't know these laws and you're working in the Texas Workers' Compensation area, you need to know these laws and you need to take the time to read them. They're very complicated. I'm not even going to pretend that I understand all these laws because there's a lot to them, but the gist of all of this is that there are certain visits that have to be done by the physician. So make sure if you're working as an APRN with worker comp patients that you're not doing any of the required visits, any of the visits that are required to be done by the physician. Those visits include medical examinations that are ordered by the commissioner to resolve any issues about the appropriateness of health care received, visits to determine maximum medical improvement and impairment ratings, or examination to define compensatory injury. It does appear that as APRNs are able to participate in the treatment of these patients, and starting in September of 2019, they will be able to sign status reports. Again, if you have any questions about what you can or cannot do, the best thing for you to do is to talk with an attorney about the Texas workers' compensation laws. So other common considerations. So often I hear from nurse practitioners or students who are graduating is, can you work as an RN after you graduate? And the bottom line is yes. There is a facility in the Dallas-Fort Worth area that is telling their RNs who've gone back to school that once you graduate, you cannot work as an RN after you graduate. That may be a facility policy, but it's a wrong policy, and I don't agree with it at all. What a former student had told me is that her nurse manager said that she could not continue to work after she graduated because if there was an emergency and she failed to act, that she could be held accountable, the hospital could be held accountable. And so that's not completely true, and there's a lot of things that goes into being able to act as a nurse practitioner afterwards. So the Board of Nursing, one, recognizes that the role is different at the RN level versus the APRN level. So after you graduate, while you are have the education of APRN, you are not necessarily licensed to work at the APRN level. So you're not required to respond as an APRN. Two, you can't do anything in the hospital without having the privileges of the APRN to do that. Three, an RN, when you're working as an RN, you are working under an RN job description with the RN expectations. You're not working with the APRN expectations. And so you are obligated only at the RN level. And you can't, everything that we do as an APRN is a delegated act. You cannot do anything without having a delegation agreement in place with a physician. So there's so many things that come into play there that come into consideration that these facilities who are telling the RNs this is not reasonable, it's not appropriate. So just be aware of that. The caveat to this is once you graduate and you have this higher level of education, even if you're just working as the RN, you are always held accountable to your highest level of education. So as an RN, if you find yourself in a situation that you're like, oh God, this is what the diagnosis is, and you know that because of your APRN education, even though you're not licensed as an APRN or you're not in the APRN role now, after you graduate, even after you graduate, if you're just in that RN role, but you recognize something because of your APRN education, you are required by the board to act as an RN on that knowledge. That is why you are always held up. That's why I say you're always held accountable to your highest level of education. So to give you an example, the Board of Nursing sanctioned a pediatric nurse practitioner who was working as an RN because of an inappropriate actions. And so what happened was this PNP was working in a public health clinic, did an evaluation of this infant, and did the hip click evaluation. So she was looking for a click in the hip, and she found one. She did not report it to anybody, and somehow I don't know what the outcome of all this was, but she didn't report it to the provider. She got reported to the Board of Nursing. The Board of Nursing held her accountable, saying that as a pediatric nurse practitioner, even though she was working at the RN level, she was held accountable for that knowledge, because as a PMP, she should have known what that meant, and she should have taken the step that any RN would have done with her knowledge and reported that to the appropriate physician or the appropriate provider. So that's how you're held accountable to your highest level of education. You're not you the board did not expect her to act as a PMP, but they expected her to act as an RN on her knowledge that she acquired as a PMP. So can you work as an RN after you have an NP license? The answer is yes, absolutely you can. Again, the board recognizes that this scopes are two totally different scopes. So you can, my recommendation to you is that you do it in two separate facilities or organizations so that there's no confusion about it. So if you work as an RN at, let's say, one hospital A, and then you want to work as an APRN at hospital B, then and they're two separate entities, that's probably the best. If you're doing both at hospital A, it can get confusing and can be gray area, and I recommend that you stay away from gray areas. Is giving medical advice to a friend or family member or to anyone you have not officially seen appropriate? So I would tell you no, do not do this, because you can be held accountable for anything that you tell them. And if something goes wrong, they're going to sue. And in the state of Texas, any malpractice lawsuits are an automatic report to the Board of Nursing. So it's best to say refer them to their provider. I often have students that will ask me for medical advice and via email, and I say I tell them very politely, I can't tell you what to do. You really need to see your physician. Because I don't want to be held accountable for something, particularly when I haven't seen a patient. So remember, the Board of Nursing requires us to do an appropriate evaluation of patients, and before we prescribe anything, it's part of our responsibility. And so lastly, being between a rock and a hard place, there are certain situations that I do not believe are ever within our scope of practice, regardless of what state we work in. Whether it's an independent state, independent licensure state like Oregon or Washington or a multitude of other states, there's a number of them, or whether we're in a delegation state such as Texas or California. Certain situations are just never within our scope of practice. And so I will tell you about a scenario that was told to me. I was not in this situation. And so one of my colleagues told me, who works in an acute care facility as an intensivist at night, received a call from the emergency room on a lady who was hypoxic. She was in the 80s. She was vented and receiving 100% FiO2, and her O2 sats just not going up. And so she was diagnosed with a PE, and the ER physician called the nurse practitioner to present the case and say, well, would you recommend we give TPA? Well, the nurse practitioner was very astute and said, well, why are you asking me this question? It's an unstable PE. What's behind this question? So for those of you who don't know, unstable PEs are treated. The treatment is TPA to dissolve that clot, and the idea is to restore hemodynamics. And so the MP was astute to this and said, well, why are you asking me? And so they went on to say that the patient just had significant abdominal surgery one week ago. So if you know anything about TPA, recent surgery, particularly within a week, is a contraindication to TPA because it's going to likely cause bleeding. So, but the patient required the TPA. They weren't going to get any better because a maximum benefit has already been seen by the non-TPA measures. So anyway, so this is what I call between a rock and a hard place, when the treatment is going to cause the patient harm potentially, and not treating them with the appropriate treatment will cause the patient harm. These are decisions that are best made by the physicians only. These are decisions that you do not make as an APRN. And the nurse practitioner in this decision called her delegating physician and said, you need to go see this patient and make a decision. Ultimately, what I found out later is that the physicians did decide to give her the TPA. They had a long conversation with the family about the risk and benefits of both giving TPA and not giving TPA. They all decided to give the TPA, and unfortunately she did pass away. She ended up bleeding and passed away. So these are decisions, again, that are not appropriate for us as APRNs to make. These are decisions that need to be made by the physician. All right. Okay, so that is the end of this lecture. Thank you for your attention to this. I hope you found a lot of good information in here. Again, you're not going to remember everything, but hopefully you'll remember, well, Dr. Gonzalez said something about this. Maybe I need to look. So on this last slide, I've given you references and the links to the various Board of Nursing rules and regulations, etc., and the various Texas laws and bills, etc. So feel free to use these to your benefit, and good luck to you all, and have a wonderful, wonderful day.